afternoon, everyone. And I just wanted to welcome you. It might be afternoon here, but evening for some people and other times depending on where you are. On behalf of the Institute on Aging and Lifelong Health here at the University of Victoria and our Pan-Canadian research team that's focused on the challenges in home care in Canada, I'd like to welcome you and our special guests. Before we begin, I'd like to acknowledge with respect the Lekwungen peoples on whose traditional territory the university stands, and the Songhees, Esquimalt, and Wasanic peoples on whose historical relationship to the land continues to this day. My name is Kelli Stajduhar, and I'm a professor here in the School of Nursing and a research fellow at the Institute on Aging and Lifelong Health at UVic. And today I'll be co-hosting our panel with my colleague, Dr. Damien Contandriopoulos, who I'll introduce in a moment. Just a few housekeeping notes. As an audience member, your audio is muted, and so only our panelists will be on video. The event is being recorded and it will be posted on our Institute website for people that want to view it later or pass it on to their colleagues and friends. And we have a kind of a format of a panel presentation. Each speaker will be speaking for about 10 minutes, and that will be followed by a more in-depth discussion involving the panelists. Because of our time limits, we're not going to be taking questions from the audience, but you can put questions in your chat, in the chat, and we will track them, and Damien and I can address those questions at a later time. So I just want to introduce our topic today. So we have a research team that's been engaged in a study focused on home care in Canada. And though it's been delayed somewhat by COVID, we thought the timing might be good to start our discussions about home care. Almost a year ago, one of the PhD students that's working with us, Tanya Sanders, and I published an op-ed arguing for the need to have a greater focus on home care. And I think some of the issues that have been going on in home care have been long acknowledged, but COVID-19 has certainly brought them into focus, and particularly related to care for older adults in our country. We've had a lot of focus on Canada's residents of long-term care and the resultant deaths, and that is a space and an area that I do a lot of work in, but we also need to consider how such a tragedy in long-term care could have been prevented or at least mitigated in the first place. Today, we're talking about home care, the sector of our healthcare system that has for some time been showing clear signs of strain, but it is also a sector that has high potential to not only enhance quality of care for aging populations and to keep them out of institutions, but if we could get it right, we could do a very good job. But how do we move that agenda forward? Two of our panelists today, who I'll be introducing in a moment, will share some of the preliminary findings from our current home care research. And we have invited our special guest, André Picard, to share his reflections on what is needed to improve Canada's home care system. So I'll just make some introductions. Cynthia Yamamoto, she is a PhD student working in our study. She has a background in occupational therapy, and she's currently working toward her interdisciplinary PhD in sociology and rehabilitation with her advisor, Dr. Laura Funk at the University of Manitoba. Dr. Damien Contandriopoulos held a CIHR Applied Public Health Chair between 2014 and 2019. His main areas of research are focused on the analysis of health policy-making processes, the use of evidence in decision-making, and the analysis of nurse-intensive models of healthcare delivery. And Damien also co-leads this current CIHR project on home care along with myself. André Picard is one of Canada's top health and public policy observers and commentators. He has been a part of the Globe and Mail team since 1987, where he is a health reporter and columnist, and I believe yesterday was his 34th anniversary with the Globe and Mail. He is also the author of 5 best-selling books, including his latest, Neglected No More: The Urgent Need to Improve the Lives of Canada's Elders in the Wake of a Pandemic. He is an 8-time nominee for the National Newspaper Awards, Canada's top journalism prize, and he is the past winner of the prestigious Michener Award for Meritorious Public Service Journalism. He was named Canada's first public health hero by the Canadian Public Health Association and a champion of mental health by the Canadian Alliance on Mental Health and Mental Illness. He received the Queen Elizabeth II Diamond Jubilee Medal for his dedication to improving healthcare. We're happy to have him here with us today. And I want to welcome all of our panelists. And we are going to begin with Cynthia. So I'll hand it over to you, Cynthia.
Thank you for having me and for the introduction, Kelly. I'll jump right in. The COVID-19 pandemic has forced a renewed attention to this issue of institution-based versus community care. And this is reflected in the increasing attention to older adults, long-term care, and home care in the news over the last year. As part of the Tackling the Home Care Challenge research initiative, we're also doing a media analysis to look at how home care is represented or framed in mainstream news coverage in Canada. And I'd like to outline a few of our preliminary results. The first is that the pandemic is situated as really having put the spotlight on the need for investment to address inadequacies and problems in systems of care for older adults. And the news has shifted somewhat over time. Initially, the horrors of long-term care were a headline focus, and as the pandemic progressed, more questions are being asked about home care and the future of older adult care, with the cautionary question being posed, will we care about this after the pandemic is over? So the problem of home care in particular is depicted as one of underfunding and understaffing, and particular groups like personal support workers are identified as underpaid and undervalued. This is situated as having long been a problem, only amplified by the pandemic. At times, the need for change is also aligned with the idea that the virus is exposing society's ageism and the myth that we value seniors. So overall, there's a sense of urgency of the problem of what's sometimes referred to as elder care and a call to action around service reform. Another piece is that in these articles, home care itself is often assumed to have common sense or face value meaning. It's rarely defined in and of itself, but rather is broadly constructed in relation to long-term care. So by what it is not and by what it is a preferred alternative to. And defining home care through comparison to long-term care plays out in several ways. For instance, the need for change is often tied to a political narrative, such as criticisms of current regimes or as part of a running platform. We promise to invest more in our seniors, to do better by our seniors, and this is often in the vague form of investment. We will invest more. In what exactly? There's also a fiscal or economic message evident, although home care is positioned as lacking or insufficient. It's simultaneously seen as a cost-effective alternative to long-term institutional care. So something to reduce pressures on an overburdened, costly, and unsustainable system. The need for investment in home care is also framed as a moral imperative. so as the right thing to do. So home care is simultaneously presented in contrast to long-term care as more cost-effective, more comfortable, safer, but also what older adults themselves want. And this idea of safety and aging at home takes on particular symbolic weight in the COVID context with associated isolation and lockdown policies, and where long-term care has become even more unappealing than it was before, and something to be feared. In constructing the call to action, media articles will commonly draw on vivid accounts of scandalous neglect in long-term care during the pandemic. These are often stories of particular families using language, images, and testimonials that really have evocative impact on the reader. And this infuses our understanding of long-term care and our home care with a sense of tragedy and horror. The call to action is also framed in reference to a kind of countdown to an aging apocalypse or an impending tsunami, with the sentiment being that it's bad now and will only get worse. And I think the language used of a natural disaster or even a war zone or battle is intended to draw attention to the urgency and the size of the problem. So the virus is seen as exacerbating existing problems, but we also have this real sense of inevitability that's conveyed of the, quote, elder crisis yet to come. We've also found that older people tend to be depicted in the media as needy, suffering, and vulnerable. They may be referred to as the elderly, the disabled, the cognitively impaired, the too often forgotten. And this is sort of echoing a broader tendency in Western societies to view aging as a state of decline, requiring specialized healthcare intervention. Older adults also tend to be depicted as passive and without agency during the pandemic, and this is seen in accounts of older people as victims, for instance, marooned by a shipwrecked system. And these moving stories and accounts of victimization are, I think, intended to help communicate the enormity of the need for change and a sense of collective responsibility. But we might consider whether this de-emphasizes older adults' autonomy, constructs a negative picture of aging, and in some ways homogenizes our understanding of what is a very diverse group. In media accounts, the spaces involved in care are also constructed in particular ways. For instance, this idea of home is characterized seemingly universally as a place of happiness, of safety, independence, autonomy, privacy, and dignity. And yet we know this may not be the case for all older people. In comparison to home, the institution is constructed as a place where people languish in their rooms, a place of wait lists, loneliness, neglect, a ticking time bomb for the spread of disease, and yet a terrible kind of necessity. Lastly, there's a real sense of tension in these articles between the weight and scope of the problem and the solutions offered, if at all present. So you have these vivid depictions of tragedy and neglect, and the next headline might be something like, hey, here's a tax break for seniors, or volunteer today, or here are some tips on aging successfully, free online courses if you're doing unpaid familial care work. So these are really surface level, individualized options. And so I think we're left with a feeling of disconnect between the horrors as depicted of what's happening and discussions of where we're going in terms of the scope of actionable change. So this project is still developing, and our hope is that this kind of analysis can help serve as a springboard for public discussion around the meaning and purpose of home care, but also for encouraging greater reflection, I think, at times on how, in our efforts to persuade the public and to argue for change, that's very much needed. We may be unintentionally reproducing certain more limited ways of viewing older adults, old age, home, and the aging process. And so more research is needed on how framing and public discourses might shape our collective ability as Canadians to think about and to address change in home care. And so that's where we're at for now. And with that, I'll hand the discussion over to Damien to talk about the other research that's going on. Thank you.
Thanks a lot. And I think we'll probably lend to similar conclusions. I'm really sorry that there's a mowing machine in my background, so you'll probably, but it's Victoria, so it's either birds chirping or lawnmowers, and today it's going to be a lawnmower. What I've been involved in that project is mostly reviewing the scientific literature. We did a quite extensive search, and I won't bore you with the methods, but we've tried to address two questions and trying to see what's in the scientific literature that could help us understand those two questions. Questions are, what is the intervention? So what's home care? How is it defined? What's the boundaries? What's in it? And the second question is, what does it do? So what are the effects? And what is the evidence on its effectiveness? Does it work? How does it work? When does it work? And that kind of stuff. And when we started the review, so overall we scanned through thousands of papers. We selected over 100. I was hopeful we would find an operational definition of what's home care, because, you know, home care is a thing. It's something we talk about. It's in budget, it's in literature, it's in newspapers. But I'm very sorry to report there is no such thing as a good definition of home care. We don't actually know what it is. The only definition that we can find are whatever services, health-related, in very broad terms, that are provided into people's homes. And it also includes whatever coordination is provided remotely to those people. So it's extremely broad. And in the content, you can also see that it ranges from highly specialized medical intervention, think end of life, oncology, mental health, all the way to providing groceries and home cleaning and stuff like this. The bulk being in between in terms of specialization, mostly provided by nurses, occupational therapists, care aides, and so on. And it's about supporting people so that they are able to attend to their basic needs. And it includes a huge range of stuff, and I'll get back to this, but what's important here is to see that in the literature, when you look at what home care is supposed to do, there are two different levels. First one is about the person. So how to improve the recipient or the carer's quality of life, satisfaction, longevity, health, that kind of stuff. So it's focused on who's receiving the service. The other level is focused on society. It deals with things like effectiveness, efficiency, how much resources would be needed, where should those resources be invested, what's the opportunity cost of putting resources here instead of there. And those questions really are focused on general society's values. And it's important to understand that there's not always convergence between those two levels. Thinking lots of resources, giving it to few people would be great for those people, but it wouldn't be great from a society perspective. So when trying to figure out what's home care, it's important to figure out that even the objectives tend to be multiple and potentially diverging. In 2 words, so does it work? It's complicated. Among the studies we reviewed, those that dealt with assessing the effectiveness of the intervention, about half of those found no effect or very tiny effects of the intervention they assessed. So that's one important policy lesson here. If it were easy, then it would always work. It's not the case. Many groups, I'm talking about governments or academics, design home care intervention, trying to figure out if they work, and found out they didn't really work. It's also really important to figure out what those studies are. Those studies are someone somewhere has a great idea and they, well, whatever, what if we sent nurses every week to people's house to assess their needs? What if the team was interprofessional instead of just nurses? What if we had, and then that's the intervention, a new idea. But how is that intervention assessed? Well, it's assessed in comparison to something else. And the something else does some pretty heavy lifting here. You have the intervention as compared to usual care. And what's usual care? Well, usual care depends a lot where the study is done. Usual care is not the same in Georgia and in Sweden, on which population you're talking about and when was the study conducted. So there's very little in that evidence that allows figuring out. If you take Canada, for example, Canada tends to be on the lower end of the spectrum in terms of what it offers, and it tends to be very, it varies a lot in terms of where you are in Canada and who you are. So would an intervention deemed non-effective as compared to usual care in Denmark be suddenly extremely effective compared to the not very much that we offer in Canada? That's an open question, and a question that the science currently doesn't answer. We only found 3 studies that compared home care as opposed to nothing. And all those 3 studies are, not very surprisingly, from the US, and they all found that it's better to offer something than nothing. It's not exactly a revelation, but it's still something that's probably important to take into account. Friendly tip for our research fellows here: if you want to test your new idea in home care, I strongly suggest you try it in Georgia or Florida, but not in Denmark or Sweden, but just, you know, we do whatever you want. Now, what works? We did find a few snippets of information of what seems transversally to be things that work in the interventions. Well, yeah, offering something as opposed to offering nothing. That's a good idea to start with. Coordination, because our home, our healthcare and social support services are poorly integrated, because our healthcare system is kind of messy, and because a recipient of home care tend to be frail people that need support in order to figure out their way in the system. Providing them with coordination support, providing them with help accessing the services that they are eligible to and that they need does make a difference. The second thing is integration of various stuff. We think about home care and we tend to think about healthcare. It's not the same. A big chunk of home care is not healthcare. It's about providing with people with safe homes, modifying those homes in order to make them safe, providing people with living conditions that improves their quality of life, and even things like socializing. Many of the interventions where nurses, for example, go to see people and assess their needs, it's not so much about the fact that the nurse properly assesses the needs and provides services. It's about the fact someone rings on the people's door and talks to them for a while, and human context does make a difference. And that's also something super interesting in the literature, is that relational continuity, the fact that it's the same person that comes to your home week after week, is central. And the literature tends to be written as, oh, the nurse comes or the doctor comes, as if a nurse is a nurse and whatever nurse comes is fine. It's not about roles, it's about people. It's about Ashley or Danielle or whoever the nurse is. And this is central. Home care is often analyzed in ways that are highly medical and technical, but at the very core, it's probably not something whose effects are explained by medical and technical things. It's probably an intervention that is mostly social and human, and that's what explains why it works or doesn't work. Last few words. So, what does it mean if someone were to want to improve the system? Well, it means, first, it would be important to start from the beginning. Government jurisdiction that would think about improving home care should start by having a serious give serious thought to what exactly is the goal here. Like instead of, I don't know, giving $12 million to TELUS to send people gadgets, I'm not, absolutely not targeting BC. That's totally an accident, and it does not relate to a budget that was released yesterday. But what about thinking about what makes a difference? So what do we want to achieve? Is it lowering long-term care admissions? Is it improving people's quality of life? Is it allowing people to live longer in general? Is it allowing people to stay home longer? Is it to create a more equitable society? Is it making sure that the values of the society are actually reflected in the kind of services that we offer? All those are fundamental elements that need to be addressed as a first step. And it's important to point out those are not science. This is about political and social debates. The science can only come afterwards. Only when the society has answered those questions, then the science can say something about, okay, you want to achieve this. Well, we might have clues about how to achieve this. What kind of intervention do produce those effects? And among those interventions, what are those that seem to be the more effective or efficient? And in Canada, overall, historically, we tended to just offer services on the basis of, well, it's possible right now. So it's kind of very piecemeal approach, and it's often not a lot. If Canada were to be serious in trying to figure out how to have a strong home care services, would go the other way around. What is it we want to do actually? And I think, André, it's going to be your time.
Well, thank you. Thank you for that. Two very interesting presentations, hard acts to follow. I want to thank you for the invitation. I wish I could be there live in Victoria listening to the lawnmower, but I am here in lovely Vancouver today, so that's not too bad. Now, as you heard in the introduction, I've written a book about elder care. So I'm interested in where home care fits in this continuum of care, some of these social, philosophical issues as much as the medical ones. So I want to begin with a bit of context, which is, about our larger health system and about Medicare. So structurally, I think we have to remember we have a sickness care system. We don't really have a healthcare system in Canada. It's all about sickness care. And similarly, Medicare is really not just public insurance, it's public acute care insurance. So, we fund 100% of hospital and physician care, and everything else is funded only partially, including home care. And there's not really any coherent rhyme or reason to why we do or don't fund things and to what degree beyond hospitals and doctors. So I think that context is important. And home care, as I mentioned, is a good example of this. Home care in Canada, to me, is essentially an extension of acute care in hospitals. That's a reminder of just how hospital-centric our system is. Even when people go home, the hospital goes with them. It's not a different kind of care. It's a way of getting patients out of beds quicker and then giving them a bit of follow-up care in their home. It's not Denmark. We've heard Denmark mentioned a couple of times. That's not what it is. It's very different. Now, what people want, I think what many people want from home care is support to stay in their homes. And of course, as we heard, not everybody has an ideal home. Not everyone wants that. But I think it's true of many people. And it's especially true of elders with who are fairly, well in a stable life condition, but they have a number of chronic conditions and they need an increasing amount of help with the activities of daily living. So they need basic stuff and a little bit of medical care on the side. Again, it's a reminder that, we spend a lot of money on home care as well. Sorry, I clicked my screen and I jumped a page there. Yeah, so people want this help with really basic stuff. We also spend a lot of money on healthcare, on home care, somewhere between $6 billion and $15 billion a year in Canada, depending on what reports you read. And even that wide range tells us we don't really know how much we spend. You heard from the two other speakers made the very important point that we don't have a clear definition of what home care means, and that of course is important too. Is it just the provision of medical care? Is it supports like homemaking? Is it the Meals on Wheels? Is that home care? Is it just acute? Is it chronic? What about palliative care? We want to die at home. Is that home care? So there's many questions that are unanswered, and of course lend themselves to researchers. I know a lot of researchers have tuned in. Now, I see home care principally as an alternative to institutional care, as you heard. So to me, it's a social issue. It's a political issue. It's not only a way of getting people out of hospital sooner, but it's a way of them remaining at home longer. I think an important part of elder care that's neglected is that we take it when we send people off to homes, we kind of strip them of their citizenship. In my book, I call our practice elder apartheid. We just kind of shunt people off to the side. And I think integrating people into the community is a really important philosophical issue, whether it saves money or costs money or whatever. Now, of course, home, as you heard, can have many meanings too. It can be the single family home, it can be an apartment, it can be a retirement home, even a shelter. I think we can provide home care to homeless people, ironically. The right care at the right place at the right time is the mantra I'm always talking about. I think we don't do enough of that in Canadian healthcare, and it's very hard to do so because we have a very siloed system. Now, we're not talking about COVID today specifically, but we can't talk about anything these days without mentioning the pandemic. And again, the pandemic has really shone a spotlight on elder care, on long-term care facilities in particular. The death rates in our nursing homes have been horrific. There's been roughly 23,500 pandemic deaths in Canada, and 17,000 of these occurred in these institutional settings, in nursing homes, in seniors facilities. And that's just a shocking amount of death and carnage. And of course, that's, have you heard, it's generated a lot of media coverage, as Cynthia's research showed. But in that media research, I think she was very kind on this part, but we kind of neglected the home care piece of the puzzle, I think, as journalists. One of the great ironies of COVID-19 was that we've spent the past 14 months telling people to stay home, telling them that home is the safest place to be. But at the same time, we've essentially shut down home care services. We've lost a lot of basic home care, and people have been left with nothing. Or even worse, a lot of them have ended up in hospital, or they've ended up in long-term care homes, which are far less safe in the current conditions. And many people who are shunted from home care back to institutions died as a result. So to me, we have to remember that our health policies, when they're incoherent, they can actually be deadly. They're just not frustrating and wasteful, but they are deadly. And this is, again, an example of that. Now, Canadians love their Medicare system. We all know that, and for many good reasons, but we tend to assume that Medicare is going to take good care of us as we age. And that, unfortunately, is not true. Unless you need hospital or physician care, or to a large extent, prescription drugs if you're older, you pretty well fall off the cliff. You don't get taken care of very well. And again, what most people need is not acute care. They need chronic care. They need help with the activities of daily living. And they're can be very expensive to grow old in Canada, because we have this assumption it's not going to cost anything, and then we're surprised when we reach a certain age and a certain amount of ricketiness. And given my age and my hair color, I can use that terminology. Now, long-term care costs anywhere from $1,200 to $15,000 a month in Canada. Now, we provide a little bit of funding, but that's strictly for the medical care, and you're on the hook for everything else. And you don't get those costs subsidized essentially unless you're destitute, unless you've exhausted all your assets and often your family's assets. And the same is true often for home care. Most provinces offer a maximum of 3 hours daily if you're getting routine care. So 90 hours in any 30-day period is usually the maximum in most provinces. If you want more, you have to pay out of pocket. And many people do pay out of pocket. As I mentioned, we spend billions of dollars, roughly $15 billion on home care, and about half of that is out-of-pocket costs. Now, say you want an additional, say you get your 3 hours, you're maxed out, and you want 3 more hours of care, which still leaves you 18 hours a day without help. That's going to cost you money. That's going to cost you about $100 a day or $3,000 a month. So again, it costs as much as long-term care. So everything in the system funnels us towards this place we don't want to be. Home care is also the only healthcare service really that has arbitrary caps. I often say to people, you know, imagine if I said to you, you have cancer, you need 10 hours of chemotherapy, but sorry, the rule is we only cover 3 hours. You're going to have to figure out how to pay for the rest. That's essentially how home care operates. You don't get what you need, you get what you're given, which is often the bare minimum. Again, a lot of residents, families purchase care not only for people in at home, but from home care agencies, from a lot of under the table purchasing now because it's expensive. And one of the great ironies for me when I was researching the book is learning that much of the long-term care in Canada is actually delivered in long-term care facilities. Because again, people don't get that much hands-on care. They get about 3 hours a day. In BC, the law is 3.36 hours you're supposed to get, but as many reports have shown, most homes don't grant that. So it kind of boggles the mind that you pay for home care as well as paying for long-term care. So you just have this really expensive rent and inadequate care. So to me, it makes more sense to, again, shuffle it to the community. Now, while we're talking about money, the last thing I'll mention is the principal argument against providing more home care is always that it's too costly, right? But to me, what's costly in this system is the bureaucracy. About 1/3 of all our home care spending, so $5 billion out of 15, about 1/3 goes to assessment. In other words, it tends to be money that's spent on figuring out how to avoid spending it on actual care. Again, to me, this is another perversity of our system, this bureaucracy. It's very much like a US HMO. They spend a lot of money figuring out how not to care for you. Now, we don't have a lot of cost-related research in Canada. I don't think Damien mentioned much about the cost. We had good research, but it's 20, 25 years old. So we don't know how it is cost-effective compared to institutional care. But to me, at the very least, we could give people choice of how they spend how government dollars are spent. So nursing homes get roughly $200 a day per resident in subsidies. Imagine if people could avoid or at least delay going to an institution, how much they could do that if we gave them $200 a day on home care. That would be a zero-sum game. It would cost not a penny more, but it would give people more choice, and it would keep a lot of people, I think, out of institutions for a certain time. Now, one of the big unknowns is how much will change in the post-COVID world. I think we don't know yet, but there are some hints, and I think they're not that promising, unfortunately. To me, the worst possible outcome of the pandemic is we just build more long-term care beds. You know, we don't need more mediocre care. We need better quality care. We need a more variety of options. And one of those options should be more home care. In the recent federal budget, the government allocated $3 billion to the creation of long-term care standards. I would think we should also have standards for the provision of long-term care, and maybe with a few $1 billion there tossed in for good measure. But there was not any money to speak of for home care in the federal budget. There's a little bit of money to encourage people to volunteer to help elders, to cook for them. I'm not sure that quite cuts it. You heard Damien make a passing reference to the BC budget. $68 million to train healthcare aides, a little bit, $12 million for gadgets, Bluetooth gadgets. Again, these are just window dressing at best. So my time's up, so let me end with one last observation. During my book tour, my virtual book tour, I've done a number of call-in shows, and a lot of them have been asking a really, I think, important and broad question, asking people, where do you want to live as you age? I think that's the kind of societal questions we need to ask and answer, and then provide answers to with policy. Now, unsurprisingly, I'd say about 100% of people who call into these shows say they want to live at home. They want to live at home, they want to die at home. And when you ask them why, there's 3 words that they cite again and again: autonomy, respect, and dignity. And that's essentially how people want to live their lives. And it's how they want to die. They want to die with some control over their lives, some autonomy. They want respectful care, and they want it to be delivered in a dignified manner. So to me, that should be our aim. And once you have that philosophy, that valuing of people, putting our values into action. That's the easy part. That's plumbing. But we have to get that philosophy in place. And to me, the old expression really applies that there's no place like home. So we have to figure out how to do that effectively and the way that people want. So thanks again. I look forward to the panel discussion.
It's great. So I'm going to ask all the panelists to put their mics on. And maybe I'll just start with a question to get some conversation going. And so it kind of relates to, so we're in the middle of this study, and one of the things that is part of this study is we're talking with people in home care in 3 cities in Canada. So we're talking with staff that work in home care, and we're also, once we can get into doing observations, we're taking a really close look at the work of home care providers, what they do, what structures the work. And so at a time when we can get in to do those observations, we'll get a better picture. But one of the things that is really clear from our interviews and I've been doing work in home care for a very long time, is this kind of pull away from the clients of home care, the patients and their families, and to a point where providers, home care nurses and others are talking about how they spend so much time at their computers, almost as much time at their computers as they do with the people that they care for. And for all reasons, coordinating care, all of those things, but a very strong sense that we're not able to provide the kind of relational continuity that I think has shown up in our literature review and coordination that's so very important for people. And I wonder if anybody can comment on all of those systems that we put in place that are to try to make the system more efficient, and to try and make communication among providers better, but actually is taking time away from the people that our system is supposed to be designed to serve.
Is the goal to make the system more efficient, or is the goal to make the system cheaper? That's an open question. I would say, to some extent, what we see is bureaucratization of the processes. It's a deprofessionalization of the processes. So the nurses and the OT and whoever works have less and less control over deciding what services they offer, how much, and when. And more you have top-down processes that they need to follow in order to fulfill the rules. And what André described of the big machine that measures the needs in a very standardized way, in a very impersonal and inhuman way, to allocate little chunks of services, and how we chop people into little chunks. So that person needs half an hour of bath, and as soon as a system tries to fulfill human needs in little boxes and tick boxes, it usually fails. And a big part of the literature is effectiveness centered, but in a very unhuman way. By opposition, you have systems that have been more effective. I think Bertzorg in the Netherlands, trying to work with smaller team, no bureaucracy, and more professional autonomy. So if I were out of my hat just to try to randomly think about what would be a more effective system, it would have those characteristics.
Yeah, if I could jump in, I would say when I talk to providers, it's very similar to what Damien said. A great frustration at not being able to just care for people, to just have to fulfill these tasks like it's an assembly line. Talking to old experienced home care nurses, they say, I remember when I used to come in and sit down and have tea, and my patients were much better off for that. It wasn't, it's Tuesday, so you have to have a bath, whether you want a bath or not. That's what my chart says. And we do all this, there is lots of bureaucracy. People, they need a care plan, but they don't need 12 care plans. And that's what they have now. And everybody has to check a different box. And we've lost the person in all this. There's so many measures, and I don't know of any measure that says, are you happy? Are you happy with what you're getting? Is this what you want? Nobody ever asks that question. People get all kinds of stuff they don't want, and they don't get what they want, which is often, just sit down and talk to me. You know, while you're doing the dishes, making me lunch, actually talk to me. Don't have to do it in 3 seconds, etc. So yeah, we have to make the system, can't just talk a good game about patient-centered and person-centered. We actually have to put it into our policies.
Yeah, and I guess I'll just add, Andre talked about sort of the amount of time that's put into assessment. And I don't work in home care, but as an OT, it's really hard for providers as well, because you find yourself beholden to these very medicalized forms with those check boxes that you have to fill out. And yet there's this whole side of you that's really wanting to advocate for the person. So you have very little control over what you can do in the you know, monster machine that is the system, but you try and develop these forms of resistance where you can at least try and advocate here and there and through comments and things like that. But yeah, it's hard on I think clients, but also providers who are held to these unrealistic standards and this very reductionist kind of biomedical framing of what it is that they have to do, that like Damien said, is social care as well. So yeah.
And I would connect with what Andre said earlier. So would it work to give people more control over what they can buy? And that's something that has been tried in different places with variable results, I would say. So what the studies say about that kind of approach is it works very well for a subgroup of the recipients, but there's a pretty small subgroup, is those people that don't have mental health issue, that they're not cognitively impaired, that they're still pretty well organized, that they're still pretty autonomous, often younger, and that need a little bit of help, but that don't need 10 hours a day. Those people do like a lot the capacity to buy, but if the system rests on this, what it actually does, it puts huge pressures on the care. And because then you have someone else, a daughter, a husband, someone that needs to go through all the hiring and finding and assessing, which is also very heavy. So I would say the balance probably needs to be not, you know, sending people a check and like, good luck to you, nor here's the Soviet style, everyone has the same thing and here's your soup and everyone eats the same soup kind of approach. Where is the balance in between? But I think it's the role of the system, health and social system, not to just give people money, but to actually provide them what they need. And in terms of what they need, the system currently seems to be overly focused on preventing long-term care readmission and admissions, because that's expensive from the system point of view, and not preoccupied enough about figuring out what people would like and how they perceive what they're being offered to contribute to their quality of life.
Well, I think the other kind of demand is to get people out of the acute care sector. And, you know, the stories on the ground that we hear from home care providers is that people come out of hospital, they're much sicker and much more complex with acute needs than they ever were before. So they're the clients that they're caring for who have, you know, long-standing chronic illness or are in need of palliative care, for example, get deprioritized to meet those acute needs, and even some of home care as well is kind of being shaped into clinics. So, you know, there'll be wound care clinics operating in the community that people have to come to, but all under the umbrella of home care, and home care nurses are pulled into, for example, those kind of clinic situations. So I think it is, you know, trying to prevent people from going into institution, but also trying to take the people that are in acute care that shouldn't be there, don't need to be there in the first place, dumping them back into home care, which creates a kind of hospital at home situation of which home care is not necessarily prepared for. and it's not been, you know, historically within the realm of what they've been doing. And that's where you hear a lot from home care providers who say our practices just, it has become entirely different than it was even 10 years ago.
And what's slightly frustrating is when you look at the post-COVID world that André talked a bit about, the current budget, federal and provincial in BC that we've just seen, are really the squeaky wheel gets the oil approach. People died and drove in settings that were actually extremely dangerous for the human beings that were there. And because of that failure, well, the policy focus is on long-term care. Because long-term care failed to a huge extent, it's the paradox is that people that were still in their home did not die to the same extent. They were saved by the fact that they were autonomous and in their home. And I'm curious to hear about how could there would be a policy entry point that would allow the governments to see the benefit and not only plug holes, but also think in a more proactive way. So how could we make sure that we don't have holes to fix in the future?
I think that's a big question. The question is, why are governments? How can you make governments not just reactive? And I think that's a much larger question. I think it's a very difficult one. Our whole system, with 4-year terms, short turnovers, it all lends itself to just being reactive, to plugging the holes, to not being thoughtful. It would be great if we were Denmark and in the 1980s we started thinking about this stuff, and that we just didn't do it after we had 17,000 dead. But that's our reality. Is we have all these dead people, they have to respond, and you don't get good policy like that.
But same time, Canada's population is growing older. The number of voters that are currently worried about what's going to be their fate in 10 or 20 years is a significant portion of the electorate. And I'm like you, André, I've never heard anyone saying, oh, I'm really looking forward for my days in the long-term care. So there could also be some significant political gains for a government that would say, hey, you know what? We have an idea that goes beyond sending you a Bluetooth gadget, that goes beyond having 90 million for volunteers that will help you cook. We actually have a plan and resources that are likely to allow people to actually stay in their home.
Well, and the reason that those promises never work is because nobody wants to admit that they're going to be in that situation, right? Everyone else is going to be in a long-term care home. It's never going to be me. Sort of the reverse lottery view. We're all convinced we're going to win the lottery, and we're all convinced we're never going to be that person in the home. So we don't talk about this stuff. So I think part of it is having this more honest conversation in society about aging. Where do you want to live when you die? Just these talks. To me, I always say that the most important social policy discussions have to take place at our kitchen tables. So many of these stories I write about, people just have to make these huge life-changing decisions in a panic because they've never, my husband's 93 and we never talked about what would happen if he ended up in hospital. Well, at some point you have to have that, and it's probably better to have that discussion at 63 than at 93. So it's all about, society. It's our fear of death, our fear of loss of autonomy is really profound. So we don't really reward politicians who say we're going to make things better. That's, again, a paradox in all this.
And I think the pervasive illusion that successful aging at home is an individual choice, right? It's all those individual level interventions. It's so much more than that. It's environmental, but people really believe that in many ways. So yeah, that's not me, but yeah.
But that's another paradox of a country like Canada that prides itself on its public healthcare system and consider it as a core part of its identity. And at the same time, well, for real, it's not that public in some important sectors. Like André said, home care is public to a tiny extent. Most of the actual support is provided by unpaid care, people that have no choice. That's the bulk. And then a big chunk is also paid out of people's pocket. And the public system only covered the remaining portion and Bluetooth gadgets. But it's just disconnected from how we conceive our society and its system. And Kelli has been in that domain much longer than me, but we've reviewed paper from Canada written 20 odd years ago. And honestly, they could have been written yesterday.
Yeah, absolutely. Yeah, I think I just want to touch on something that André said, and that is about our societal discomfort with talking about aging and dying. And you know, some other work that I do in palliative care with a colleague of mine, you know, we actually found that healthcare providers had so much more difficulty talking about these things with the people that they care about. And after 30 years of working in palliative care, I can really say that when you work with a lot of older people, the opening for these conversations is there. If you listen with intention. It's not, I don't know so much that it's that people don't want to talk about it, but they don't know how to talk about it. They do talk about it with their families. They just don't talk about it with us in healthcare, and we don't bring it up. So I think part of it is some parts of our society are kind of not wanting to talk about these things, but I actually think that we have such a biomedicalized system that cannot accept the fact that there's a natural progression and trajectory as people age, and they don't want to talk about that either.
I think we catastrophize aging too, right? Like Cynthia talked about the language, the silver tsunami stuff. And the reality is the vast majority of elders are healthy and they're active and et cetera. And we concentrate on this small portion of people who need a lot of care. And as Cynthia said, again, you know, we assume that we can control that. Like, I'm not going to ever be the person with dementia who needs to be in a home because I'm going to will it away. So again, we have to be more realistic in these conversations.
Yeah. And maybe also one of the roles, so we're in the middle of that study and we want to understand what's going on the ground and connect it to the evidence. But one of the things that could have an impact is pointing out the fact that whatever the amount of research currently being invested is not insignificant, but it's probably not well connected to people's needs and people's desires. And the way the system is currently, the direction in which it is going is likely not going to improve it in the short run. So if there is a place for research, it's probably also to point out that, you know, more checklists, more computers, more gadget, and more top-down control, that's unlikely on the long run to help much. And timesheets, like you have 30 seconds to say hello, you have 1 minute to reach the kitchen, and so on, which is the reality of home care nurses.
So any last comments before we wrap things up? Damien, do you want to wrap up for us?
A wrap up. Well, I think what we see is a strong convergence on the message, on the fact that the reality of the experience of people, what people express in terms of desire, is not what we read in the media as the description of the trend in society. What we see is a current home care system that is, at least in Canada, obviously disconnected from the challenges it's going to need to address in the future, and it's probably not doing an optimal job of the use of resources, and a big question mark on, okay, so what could change that situation? And honestly, as a researcher, it's one of those domains where we probably have too much evidence. We probably have way enough research, both in Canada and abroad, that could allow anyone to figure out, well, okay, next step would be to actually think about the important question: what do we want to achieve? What are the resources? Does it connect with society will? Is it politically feasible? And what we need, I think, in Canada is a trigger. And it's not going to be easy. When you look at the broader picture, you can see things like pharmacare. that has been like trying to reach the momentum so that it becomes a reality and then it drops back. Home care is even much further away from a turning point, further away from the time it's going to be a reality where Canadian provincial government, federal government will say, okay, we want to do it. So turn back to the research community and say, how do we manage this? And it's somewhat frustrating from a research point of view. At the same time, it's a totally unescapable social issue. And as André's book on long-term care shows, it's not going to go away. The needs of people, those needs and those people are going to be part of our society in the future. And it would be great if it didn't take thousands of deaths for those issues to be on the top of the political agenda. Is that depressing enough as a conclusion, Kelli? Or
I'll try and end you on a more optimistic note. We know the problems, we know the solutions, we have the means, and we just have to get to it. And the final thing is we've implemented a lot of the solutions in small scale, in pilot projects. We just have to take all these successes we have hiding around the country, scale them up, and we'll have dramatically better elder care without much investment and really easily. But it's just the will. That's the only thing lacking, I think.
Wonderful. Well, thank you to our panelists, and thanks to everyone who signed up. And it's been a very engaging discussion, and I hope will propel my friend Damien to believe me when I say that home care is a part of primary care, which he keeps arguing about with me. It is a primary system in our health system that needs development and support, and hopefully we'll move our way forward one step at a time. So I want to thank everybody, and I'll say good afternoon and good evening.